bariatric surgery. CMS represents a comprehensive team of surgeons, physicians, dietitians, and psychologists to assist on weight loss surgeries. Today's discussion is centered around comorbidities of obesity. Now, obesity is known to have an increased risk for developing many medical problems, including insulin resistance and type 2 diabetes mellitus, hypertension, dyslipidemia, cardiovascular disease, stroke, sleep apnea, and so on. To throw more light on this, we have our eminent speaker today, Dr. Khusrav Bajan. He's a consultant in critical care and head of emergency department. Now, obesity is known to have an increased risk at Hinduja Hospital and MRC Mumbai. Pioneer to bring the ACLS and BLS courses in India, Dr. Bajan has done extensive work in disaster relief and emergency management. He has been very enthusiastic about teaching and has authored 2 books on emergency and trauma care. We are honored to have you on the platform, sir. Requesting you to please start your presentation.
Thank you so much, Unnat. Yeah, my slide seen, right? Yeah. So at the outset, I thank Dr. Ramen Goel for inviting me for this amazing talk, which I will definitely love in interacting with all of y'all. And we know that obesity is becoming one of the biggest killers in the world and always associated with comorbidities. And therefore, in the next 20 minutes or so, I will try to take you through the evolution of obesity and what happens if obesity comes along with comorbidities and how to manage them medically. So we know that obesity worldwide, there are billions and billions, and there are nearly 30% of all individuals who are becoming overweight and obese. And India, this is a 2013 study. There is little more which I will be sharing. And we know that India was the third during the 2013, and it still holds that position. Way back in 2016, Kerala brought out a fat tax of 14.5% on pizzas and burgers. I don't know whether that helped us or not, but that was one way of doing it. In India, we need to definitely lose weight, and there are 73% of urban Indians who are overweight, and a much bigger number, which is also 1 out of 2, 1 out of 3 people who are overweight and obese. Amongst the men, 1 out of 5 are extremely obese or severely obese, and the women, 1 out of 7 are again extremely obese, and the average risk is between 28 and 38 years of age. The other statistics which are very, very glaring is that India remains to be the third in the global obesity index. Obesity prevalence has tripled in the last 40 years, 3-fold higher. And the major states with obesity in India are Punjab, Kerala, and Delhi. We sometimes like to fool ourselves by standing on 2 weighing scales and hoping that our weight would be less, or standing on one presuming that yes, we might half our actual number, or we might just in light vein tell each other that I'm not overweight, I'm just under tall. But the real problem is huge. Obesity, along with comorbidities, is an oversized problem, and it not only leads to increased mortality, but also increases the risk and morbidity and the life quality of a human being. And we usually take the height and weight into account, and we have normal, overweight, obese, and severely obese. Or we might look at the body mass index, and which is calculated by weight and kgs upon the height in meters square. And we can divide again our patients into underweight, which is also important to note, healthy, overweight, obese, and severely obese, depending on the BMIs. And I don't want to get into details because everyone knows what is what. But one thing I would like to draw your attention to, as you can see, both these men on the weighing scale are equal in their BMIs, and you might get fooled just looking at the BMI. So you, on one hand, on the left side, you have a high BMI, but a low fat index. And on the right, you have a high BMI with a high fat index. And therefore, you need to understand that you need to look at many other issues than just looking at the height, weight, and the BMI of the person. So obesity and comorbidities is the main chunk which I'm going to discuss now. They always coexist and invariably coexist. More than 3 or 4 comorbidities may happen in an obese person. And this is the usual dilemma. What came first? Did a diabetic become obese, or did an obese become diabetic, and so on and so forth? So the usual chicken and the egg story. But this is an important slide to know what all can happen along with obesity in the terms of comorbidities. So these may be complications, these may be comorbidities, and I'm going to look onto them maybe in a bit. So the migraines, depression, pseudotumors in the brain, cerebri, and obstructive sleep apnea. You go lower down and you can have asthma and even COPD. You can have the heart being involved, where there is hypertension very commonly, and cardiovascular disease. You also may have dyslipidemia and hypercholesterolemia. You would have gastroesophageal reflux, which might even mimic a cardiovascular disease and cause problems. There would be a NASH, which is a non-alcoholic fatty liver. There could be cancers, which I will again discuss. And the biggest problem would be diabetes and metabolic syndrome, stress incontinence, degenerative joints, gout, venous stasis leading to thromboembolism. And in the COVID times, we talk a lot about this venous stasis, and also polycystic ovarian syndrome. And there are leading to infertility. There could be many more than just shown in this chart. How common are they? So this is an odds ratio, and I will not discuss what is odds ratio, but every single parameter is given an odds ratio, and you can have a major depression from 1 to 21 odds ratio, and so on and so forth. So just for being statistically correct, an odds ratio can be calculated like this, where it is AD upon BC when we have a chart on the left like this. And then that would also tell us the relative risk of developing the comorbidities or the attributable risk depending upon certain statistical calculations. So we know that it is extremely common. And this is a very good chart. As you can see on the axis here, there is a BMI of less than 21 going up to more than 35, underweight, normal weight, and then obese and overweight, and severely obese. As you can see, substance abuse, peripheral arterial disease, osteoporosis, and the AAAs are actually higher in the underweight patients here. Whereas the dark blue, which you can see at the last, pulmonary hypertension, erectile dysfunction, renal failure, congestive heart failure, degenerative joints, OSAs, diabetes, hyperlipidemia, hypertension, and the metabolic syndrome actually go higher exponentially as the BMI increases. So this is an interesting finding, and it basically tells you that even underweight can have problems and not only overweight. This is, I call it the full chakra or the life's full circle. And as you can see, we know that childhood obesity is now an epidemic or a pandemic like the COVID. It can lead to adult obesity, but it can also influence on the puberty and cause impaired fertility with hypogonadism. It can lead to insulin resistance and type 2 diabetes. It can lead to dyslipidemia, hypertension, and cardiovascular disease. It can lead to increased risk of certain types of cancers. It can also lead to physical handicap, where the person may not be able to walk easily or have osteoporosis or joint problems, increased load leading to orthopedic problems, as I mentioned, and sleep apnea, and decreasing the quality of life, and certain low esteems, and leading to psychosocial and depressive attitudes. So there is so much associated with obesity that earlier obesity was not included as a disease. But now we know that even the insurance companies agree with the surgeries as part of life-saving surgeries. So what's the big deal if we have comorbidities? So just being obese is not bad enough. So yes, we need to understand why having comorbidities with obesity is very, very important. And as you can see, and I mentioned it earlier, on one hand, you will have mechanical stress leading to sleep apnea, arthritis, back pain, and leading to disability. And on the other hand, you would have insulin resistance, hypertension, dyslipidemia, sex hormonal imbalance leading to inflammatory changes, finally cardiovascular death and events and mortality. So it can not only increase the mortality 3 to 5 fold, but it can also increase the disability of a human being. So let's look at each one important comorbidities along with obesity. So the diabetes, the type 2 diabetes, it basically happens because of two things. On one hand, a pancreatic fatigue where there is an overexertion of insulin production and the pancreas can no longer produce the needed insulin. On the other hand, the cells don't respond to the insulin whichever is produced, and that is the leading to excess of glucose and therefore diabetes. And you can see this very nice circle of insulin resistance where initially there is an increase in the carb craving, then the chronic carb consumption, blood glucose levels go up, pancreas needs to secrete more insulin, cells get resistant to insulin, and then the cells struggle to produce enough energy, and the vicious cycle leading to inflammation, more insulin being produced, which leads to pancreatic fatigue, and so on and so forth. And then there is another concept with the diabetes and obesity called as the sarcopenic obesity, which is important. So in India, we just like calling anybody who is obese very healthy, but that's not the right term. And we know that the entire cycle can lead to sarcopenic obesity, where you can see that this is a lean mass where there is more muscle mass and less fat or adipose tissue. And here you will have a sarcopenic. For the same body mass index, the fat index, the adipose index is much higher. It also causes hypertension, and in hypertension, we know that it will affect not only the adipose tissues, the RAS system, the adrenals, the aldosterone, and also the sympathetic activation leading to hypertension. Obesity, as I mentioned earlier, can cause hypogonadism, but it can also cause dyslipidemia, where there will be an increase in the LDL, the triglycerides, and a decrease in the HDL, which is even compounded by less of activity. And then there will be lipid deposition and accumulation of the visceral fat in the wrong areas, the wrong arteries, and lead to death. And when we have diabetes, hypertension, dyslipidemia, along with inflammation, we call it the obesity metabolic syndrome. And we know that having that would increase the mortality by almost 5-fold. We then would have an OSA where again we have a vicious cycle between it, but the patient would have daytime somnolence and want to yawn the day along, and in the night would be snoring away to glory, not sleeping well, and causing a lot of inflammatory changes and problems in his breathing capacity, also being a nuisance to the others sleeping with them and having a disturbed sleep. So this is an actual big problem. Then you may have gallstones, and this is again very common, where gallstones are 3 times more common in females than males. But obesity is the first for high risk for gallstones, and pregnancy, diet, thalassemia, gastric surgery could be the second and third. And then the malignancies, the most dreaded. So this is one chart which actually is very, very scary. And you can see that 31% of breast cancers, 44% of kidney cancers, 60% of bowel cancers, and 22% of womb cancers can be induced by alone by obesity. And it would be inadequate for me to talk about the severe obesity and the severe course, or the mortality and morbidity that occurs when it occurs along with COVID. So an obese person getting a COVID would usually have these comorbidities which make it worse, would also have respiratory dysfunctions which COVID attacks there. So besides having COVID, they would have increased airway resistance, impaired gas exchange, and low muscle strength. And they would have the other metabolic parameters and the inflammatory parameters leading to a cytokine storm easily. And this is an amazing chart where on one side, obesity, diabetes, on the other hand, COVID-19 would actually lead to so many problems, not only in the circulation, the inflammatory markers, the cytokine storm, the kidney function, the heart function, myocarditis, lung function, and the brain also. And therefore, an obese person along with diabetes has a much higher risk when they develop COVID. And the same cycle, I won't repeat myself again and again, but leads to a lot of limitations in the critical care where these COVID patients are managed. Like prone positioning is difficult, intubation becomes difficult, and then higher ventilative pressures are required, which is against the norm of ventilating ARDS patient. So you are running with a very bad, difficult patient where you need to strike a balance between the obesity, which is already there, and the management of the patient in the critical care. And it makes a nightmare for the anesthetist, because the morning sniffing air position is the normal position we give a patient whilst we intubate. But in a morbidly obese person, we have to change that over into a ramped up position in which the ear and the sternal notch stay in the same horizontal plane. And this makes everything so much more difficult, not only to intubate, but to also ventilate these patients or even prone these patients. And then once in a while, life-threatening complications could be the presentation of an obese person, and that could be anything from honk to DKA to even dreaded pulmonary embolism, which is common, or cardiomyopathies, or even sometimes complications if the patient has undergone a bariatric surgery. But in the right hands, this would be minimized, and Dr. Goel will definitely tell you all about it. So my third part of the talk is why and how to treat the obesity, especially when it is associated with comorbidities. So there are some smart tips, and that is the old and the new way. I'll just take a couple of these. Eat less and exercise more was the old way, but eat more and exercise smarter is the new way. Slow down the metabolism, but here we need medicines and food which would speed up the metabolism and lower your set point weight, etc. So these are the important smart ways of going ahead. I would like to quote here by saying, food is the most abused anxiety drug, and exercise is the most underutilized antidepressant, and it is up to us what to make out of the obesity so that we can change ourselves to a better future. Coming to the treatment, this is a pyramid which is very important. So first, when the BMI is more than 25, we offer lifestyle modifications where diet, physical activity, and behavioral modifications are suggested. Now look at the left here, the basal metabolic index or body mass index of more than 27 with comorbidities is equal to a body mass index of more than 30 without comorbidities. So every time we manage a patient with treatment, we look at whether they have comorbidities or not. And if that is the case, then we give them pharmacotherapy. And if the body mass index is more than 35 with comorbidities or more than 40 without comorbidities, obviously they would be needing surgery. Now, this is a pyramid, but nowadays, many a times patient may need this stage if the comorbidities are more. And again, Dr. Goel, who's the absolute master in this, would tell you more. So this is a continuum of care which we should understand. And as you can see, on the right, this is the same thing. As the weight goes on increasing, we ask questions about comorbidities all the time, and try to titrate our therapy depending upon the number of comorbidities available. This is a nice chart again where we need to address the root cause, personalized and targeted therapy, easy to follow, convenient, holistic, evidence-based, and developed by obesity experts. And you need a team effort here to actually treat a single patient. And this is very nice, where you do not give guidance to every obese person, but you follow the 5 A's of obesity management, which is very, very ethical. First, you ask permission whether the person needs any help or not, assess the person, advise the person what are the problems like comorbidities, etc. Agree, both of us need to agree, the doctors and then the surgeons, the nutritionist, and the whole team needs to agree. And then we arrange things for them and we assess them in the proper management. So I would like to go through these 5 A's for most of our patients. Coming to the drugs, there are various levels where every drug would work. Phentermine, locaserine, and topiramate would actually decrease the hunger or the satiety, and therefore decrease the food intake. The caloric restriction and the bariatric surgery would act upon the food intake and the absorption. Orlistat would decrease the absorption, and physical activity and exercise would cause the fat tissue maintenance. Hedonic eating is eating for a passion, and we always say, are you living to eat or are you eating to live? And that can be also altered by the behavioral modification. So it's basically, you can see there's no one magic bullet, but it is a complete encompassment of a team effort. And then if you have to talk about drugs, which I don't need to go into details, but we divide the patient into presence of psychiatric disorders on the left and contraindications to centrally acting, as against on the right, which would be otherwise. So if there are contraindications to centrally acting anti-obesity drugs, then we would be using, as I showed in the chart, liraglutide, orlistat, canagliflozin, which is an SGLT2I inhibitor, and metformin or even hormones. But if there is absence of any psychiatric disorder or centrally acting anti-obesities can be added, then besides these 4 or 5 drugs, we could use sibutramine and or topiramate. We can use bupropion and naproxen, and sometimes we can use fluoxetine or sertraline for the anxiety that the patient might have. And this is a very important chart whilst treating a person, especially for the general physicians, when we are treating somebody with obesity and the comorbidity. So I'll take a minute to go over this chart. If we are using antidepressants, we need to know which ones will cause weight gain and make it worse, and which ones would help to lose weight or keep the weight neutral or even induce a weight loss. And therefore, in this group, nortriptyline and amitriptyline and mirtazapine and sertraline would probably increase the weight, but fluoxetine, sometimes sertraline when used for a short duration, and bupropion can induce a weight loss. If we are using antipsychotics, then olanzapine, quetiapine, and risperidone would increase the weight, but these medications, which we rarely use, can in fact be used to reduce weight. So of these, topiramate is one which we use in neurology, which is actually an anti-epileptic, but those patients who are obese and have a lot of back pain and neuropathy, people are given gabapentin as the mainstay of treatment, but that can also increase the weight. As against that, if we use lamotrigine or we use topiramate, that would help. Endocrinology, the anti-diabetics. Now we should remember that whenever we use insulin, sulfonylureas, there is weight gain, but acarbose, metformin, GLP-1 and the SGLT2, which are the newer one inhibitors, are the ones which will induce weight loss either by the stool mechanism or the urinary mechanism of excretion of sugars. Endocrinology, steroids, yes, of course, will always make a person gain weight, but the lowest dose, if needed for rheumatoid arthritis, etc., we must use. In the contraceptives, we know that depo-metroxy would increase the weight, and therefore we might have to offer them alternative therapy like an IUCD or even a low-dose combination of an oral contraceptives. In cardiology, as an antihypertensive, carvedilol, nebivolol would probably make you lose weight, but metoprolol and other beta blockers would increase weight. And then when we use antihistaminics, we should use them for a short duration because chronic use can also lead to weight gain. So this is very important in how we tailor our therapeutic pharmacotherapy in these patients with comorbidities and obesity. And now I will be able to answer my question, which I asked a few slides ago. Why and how do I treat these patients? And the reason for why is that, look at the bottom line. The quality of life is improved in 95% of the patients, and the mortality, a 5-year mortality, is reduced by 89%. This other disease can get better with just weight loss, whether it is medical or it is surgical treatment. And here, individual symptoms from migraines to PCODs to metabolic syndromes are all beyond 50 to 80% and sometimes even 93%. So this is a very, very nice slide where we can tell all our patients to encourage them and make them lose weight following the 5 A's that I mentioned. And after surgery, this is a slide. Again, I am not going to talk about it because the expert will talk better. And 9 to 12 months later, after surgery, you can see this green. Green is hypertension, diabetes, obesity, diabetes. This is, or a red line is sleep apnea, and the yellow line is hypertriglyceridemia. So the big four are definitely treated by reducing them, their incidence by almost about 1/3 to 1/3. And therefore, patients with these comorbidities after surgery might even not need any anti-diabetics or anti-triglyceride drugs or etc. I would end here by saying that the doctor of the future will give no medicine, but will instruct his patient in the care of the human frame, in diet, and in the cause and prevention of disease. And this was said by Thomas Alva Edison, who's a scientist and not a doctor, but it was so much forethinking that he mentioned this. And it's not us to treat the patient, but to follow and guide them in making them make the right choices. I cannot see this on the right because of the people seen here, but accept your past without regret, handle your present with confidence, and face your future without any comprehensions. I would end here by saying that we always see obesity very commonly, but that should be removed and very easily treatable and preventable in our management of patients, and we should start getting fit. And I thank you all for a patient hearing, and I'll be glad to discuss anything that you feel appropriate.
Thank you, Dr. Bajan. Very insightful presentation, very interesting discussion, and I like the quotes. I'm personally a very big fan of starting the presentations and ending them with the quotes. Keeps the audience engaged with you. So we have Dr. Satyanarayan and Dr. Jaikrishna with us. I think they'll have some questions with you. Dr. Jaikrishna and Dr. Satyap, can you please unmute yourself and present him with your questions? Dr. Jai, Dr. Satya, are you there with us?
Yes, I'm waiting for the questions from the audience.
I think he's waiting for Dr. Unnat. Bajan, it was excellent presentation. A completely different direction to the whole problem. You have, in 20 minutes, you covered up the whole thing so beautifully. I've heard so many talks, it's mesmerizing. And so much emphasizing the problems related to obesity. That was wonderful.
Thank you.
So let's ask the physicians, do they have any questions in mind? Dr. Jaikrishnan?
Yes, since we are waiting for the questions from the audience, can you please elaborate, while reducing the body weight, the obesity, the diabetes can be reversed, at least up to some extent. Can you throw some light on that, sir?
No, so the mechanism of diabetes, I mentioned that it is multifactorial. There is a pancreas which will become exhausted and not produce insulin finally. And on the other hand, you will have the cells which will not take up the insulin. So this can be reversed because the weight would be lost and the patient would be more active. So the entire process by which diabetes happens in these patients of obesity would be reversed with adequate weight loss.
Yeah.
Dr. Raman is the expert, so if I have not answered properly, sir, please.
I can add. I can add a few things. So one thing that we have learned after starting these surgeries for diabetes is that there are certain factors in the duodenum which are probably responsible for insulin resistance. Okay. And when the food doesn't cross the duodenum, those factors are not stimulated, and that is why the insulin resistance after bariatric surgery drastically goes down. And that frees up the insulin. That means it becomes more effective. Second thing that Dr. Jayakrishna, that can explain diabetes control after weight loss or after any obesity management is the GLP-1 secretion. So as you physicians normally use GLP-1 agonists nowadays, that is stimulated faster after a surgery, and that improves the responsiveness of beta cells towards glucose. So we talk of insulin resistance on peripheral tissue, but there is a resistance towards glucose in the beta cell. So you may have a very high blood sugar, but the pancreas are not producing beta cells. So one theory is that the beta cells are damaged. Another theory is that the beta cells are not responding to glucose challenge. When GLP-1 is secreted, that improves the responsiveness of beta cells and they start producing insulin much faster. So there are various things, it's just gut hormones, bile acids, so many things which can be responsible. And the only way to explain it is it's multifactorial. So you cannot pinpoint one reason to explain this.
And that's why when you have diabetes and obesity, you use the GLP-1, as Sir said, and the SGL2 inhibitors. The reason is that not only controls the sugar and gets a better glycemic index, but it can make the person lose weight up to 10 to 15% in 1 year. So those are the drugs which are used, and therefore it could be useful.
Yeah, I think physicians have wonderful future in obesity management. You have this, we had liraglutide, and now very recently FDA approved seraglutide, which is about 50% more effective than liraglutide. So once that products become available in India, I think physicians would be routinely managing obesity because you have once a week injection,
once a month or once a week injection which you can use, and there are lots of studies by the US FDA. It's not yet available in India, but very expensive though, extremely expensive. I think a 1 year cost would be equal to one bariatric surgery.
So bariatric surgery will become cheaper. Sorry, Dr. Jayakrishna, please go ahead.
Yes, sir. Peptide in a pill is going to come, sir. Probably by now. They are supposed to come, but they have just postponed it due to the COVID scenario. Peptide in a pill can be mainly for diabetic patients.
Yeah, I think that is the way to go. So what has happened is after bariatric surgery started for diabetes, a lot of pharma people are doing research on the mechanism that surgery works. And that is how you are getting all these drugs. So I believe in the next 15 years, probably surgery will be getting less and less used, and there will be more effective drugs coming, which will be wonderful, because ultimately surgery cannot be offered to everybody. It's only for selected number of patients. Majority of them should be managed by family physicians, not even endocrinologists.
The problem is when there is no comorbidity and there is only obesity to begin with, then it does not make sense to use so many drugs which would act on even diabetes or even dyslipidemia, etc. So, or centrally acting. So many are resistant to taking that if they don't have any, depression or diabetes. So drugs, there is no magic drug that we need to know. And it's basically everything from diet control, behavior modification, exercise, drugs, and then bariatric surgery. So it's all a full circle of these 5.
Yeah. Dr. Unnati?
Sir, a lot of new studies has come on dapagliflozin, which is definitely, it also reduces the body weight. Even that can be used for non-diabetic patients for
yes, but not advocated for non-diabetic obese. Dapagliflozin, even the canagliflozin, they are all being used. They are SLG2 inhibitors, and they definitely have a very, very good effect on the obesity if used in combination with metformin or even alone, but they cannot be given only as an anti-obesity pill.
So what is your take? But whether Cana is better or DAPA is better? Your personal experience. Your personal experience.
No. The thing is, Cana is extremely expensive, but there are some trials with it which are very promising. So if the cost is not a problem, I would still prefer a Cana.
Okay.
Nicely answered. Dr. Satya, do you have any questions? I think if not, we can move ahead to Dr. Raman's session.
Yeah.
Okay. Thank you, Dr. Bajan. It was really an insightful session. And without further ado, I would like to start the next session by Dr. Ramen Goel.
Okay. Thank you, Dr.
Now, we all know that Dr. Ramen Goel is the pioneer in bariatric surgery specialist in India, who pioneered laparoscopy surgery practice at Mumbai. He is also the member of Special Board of NB. He was trained in bariatric surgeries from France, USA, Australia, and various countries, and brings a variety of insights and vast experience in the same. Dr. Goel is the editor of Bariatric Journal and has participated in a lot of talks on COVID-19 and its prognosis in obese and hyperglycemic patients. He is also the immediate past president of IAGS. Welcome to the program, sir. Please start with your presentation.
Thank you, Dr. Nati and Docplexus, for this insightful program. Series of obesity-related programs. So every week on Thursday, we have this program. And I'm so happy because Dr. Khusrav Bajan, who is a colleague of mine at Hinduja Hospital, simplified the whole thing about comorbidities in obesity. And comorbidities in obesity have become a major issue, especially during COVID-19, because it was reported that world over, more people had severe COVID, those who had comorbidities and those who had obesity. So I think it's very relevant at the moment, and it's important that we realize the seriousness involved in obesity and related comorbidities. So I'll briefly speak. He has already covered the topic so well. This is our Center for Metabolic Surgery at Mumbai. And I'll briefly speak about a bit about bariatric surgery today. A lot of things have changed from where we started in last 21 years. So I did my first bariatric surgery in the year 2000. And in 21 years, there are a lot of new understandings in bariatric surgery. And I think since this is a program towards family physicians, it's a good platform to share those details. So first and the foremost is that the bariatric surgery, the name itself changed over a period of time. From 1966, when the bariatric surgery started all over the world, this was primarily done for weight loss. And then somewhere in 2004, surgeons realized that we can also treat diabetes. And we said that the surgery for diabetes is metabolic surgery. So we started calling this bariatric and metabolic surgery, bariatric for weight loss and metabolic for diabetes. But then over a period of last 16, 17 years, further understanding came that bariatric surgery basically works through metabolic changes in body. So there are hormonal changes, gut hormones changes, the gut bacteria changes, gut pH changes, even the bile salt enterohepatic circulation changes, and all these are metabolic changes. And thus now from 2018 we are using this term interchangeably. You can call it metabolic surgery or you can call it bariatric surgery. They are used for the same weight loss and metabolic changes that happen after surgery. Now, bariatric surgery is a weight loss option in selected patients. Why so? Because it is known that if somebody has a lifestyle change like diet and exercise, usually they end up losing 5 to 10% of their weight. But 92% of those people, like an overweight person, is likely to regain weight within 1 year of going on a lifestyle change. And 98% of those who are going for lifestyle change will regain their weight. So, though the lifestyle changes are the foundation of weight loss treatment, but the recidivism or relapse rate is very high. While after surgery, people can lose between 70 to 100% of their extra weight, and almost 75% of them maintain their weight long term, even after 10 years. And that is the difference between a lifestyle change and bariatric surgery in real terms. Now, as far as diabetes outcomes are concerned, these are various studies, but the first study, which came in 2004, said that diabetes is resolved in almost 84-85% patients. That means 85% of those patients who had diabetes before surgery will not require medicine, and their HbA1c will remain below 6.5, which was a very big news. And then Cleveland Clinic did a RCT sometime, which got over in 2018 or 19, where they compared a group of patients who had bariatric surgery versus those who had metabolic therapy, intensive metabolic therapy. And they said after 5 years, those who had bariatric surgery, their HbA1c, mean HbA1c was less by 2.1%, while those who were managed with medicine, their HbA1c was less by only 0.3%. So there is significant difference in the HbA1c reduction between patients who undergo surgery versus those who undergo medical therapy. Now, another thing that changed over years is the surgical indications. And what Dr. Bajan showed was what was approved by FDA and NIH in US way back in 1994 or 95. But then over a period of time, we realized that surgery can be offered now, let's say in India or in Asia, for people who have a BMI of 27.5, but they have uncontrolled diabetes. So now the surgery is being offered not for weight loss, because these people are almost normal weight, but it is being offered to control diabetes. And also the Indian guidelines says now that if BMI is more than 30 and patient has comorbidities like uncontrolled blood pressure, PCOD, sleep apnea, or other diseases, then we can offer surgery. So for comorbidities, we have reduced the guidelines, substantially changed the guidelines to bring it down to 30 BMI, for the simple reason that the focus should be on disease treatment and not on weight loss alone. And obviously, if there are no comorbidities, then person can be offered surgery only if the BMI is more than 37.5. So the focus shifted from weight loss to treatment of disease in last 21 years. Some procedures got added. When I started the bariatric surgery, there was only one procedure out of this, that was a lap Roux-en-Y gastric bypass. And somewhere in 2004, we started doing lap sleeve gastrectomy. In 2012, we started doing lap 1 anastomosis gastric bypass. And somewhere in 2018, we also started doing endoscopic bariatric. So the procedures have also changed, and now these are the 4 kinds of procedures which are commonly being done all over the country. There are 3 of them are surgical procedure. Just to show you a picture, this is sleeve gastrectomy, where we staple the stomach and we remove rest of the stomach. This is Roux-en-Y gastric bypass, which is also called the gold standard procedure, where we make a small stomach and join the jejunum here. So the food goes directly into jejunum and rest of the stomach and duodenum is bypassed. And this is 1 anastomosis gastric bypass, where we make like a sleeve and join the intestine so that the food directly goes into jejunum and rest of the stomach is bypassed. Now, as far as endoscopic procedures are concerned, endoscopic procedures, though they give weight loss, we do not consider them as a bariatric procedure. We do them ourselves through endoscope, and there are various types of procedure. One is called gastric balloon. I'll show you a brief video on that. Then another one is endoscopic sleeve gastroplasty, and third one is aspire assist. where we can empty the stomach like a PEG tube, and after a meal one can empty the stomach. This is FDA approved, but it's still not available in India, and they have limited weight loss. I'll talk about it in next 1 or 2 slides. So this is the kind of balloons which are available now. So this is a balloon which goes in a collapsed form in the stomach, and then balloon can be inflated inside, so it occupies part of the stomach. There are double balloons, or there is a balloon which is adjustable balloon, like a Spatz balloon, which can be kept inside for 1 year. So these are different types of balloons. I'll show you a brief video. This is an animation that how the balloon goes inside, and this is just like a Ryle's tube. The balloon is introduced, the patient is under sedation, and once the balloon is in the stomach and we put an endoscope and see its position, we inject saline in the balloon, and the balloon is inflated. This is a saline which is diluted with methylene blue, so that it's blue in color. And then once it's inflated enough, then we withdraw the tube, and the balloon remains in the stomach, and it occupies half the stomach. So it's basically the person is already half full and is eating less. Then the newer procedure is endoscopic gastroplasty, where we endoscopically put stitches from inside. So we stitch the stomach in this way and we tighten it. We stitch the stomach in this way and we tighten it. So what happens is that the stomach, which was like this, comes towards the lesser curvature. So stomach, which should have been till here, because of the stitches, it's collected towards the lesser curvature, and the sleeve is like this. So it's a sleeve gastroplasty, which can be done endoscopically, and there is no surgery involved from outside. Generally, balloons give weight loss of up to 8 to 10 kgs, and gastroplasty gives weight loss of about 15 to 18 kgs. We have been regularly publishing our data. These are 2 of our studies, which shows that at 3 years, diabetes resolution happens in almost 80 to 92% patients in India, and at 5 years, diabetes resolution happens in 64% patients. This is much better than Western data, because Indians primarily eat carbohydrates, and after surgery, they are eating more proteins. So automatically, sugars get better controlled. There are many other benefits. Dr. Bajan had already covered most of them. Like sleep apnea resolution happens in almost 95% patients. That means they don't need CPAP anymore 1 month after surgery for the rest of the life. Acidity or reflux happens in 65% patients. The joint improvement happens in 55% patients. PCOD and infertility improves in 70% patients, and the list goes on in terms of cancer reduction and many other things. Friends, as far as long-term outcomes are concerned, there is no dieting involved in this, and that's important, because the person is encouraged to eat high-protein diet. Person can eat the regular chapati or rice, all kind of vegetable, non-vegetarian items, fruits. They are encouraged to do moderate strength training, and the only restriction is that they should avoid alcohol and calorie-dense food, so that they do not get too many calories from these items. Just to show you this young lady who had a surgery, and 10 years later, after a healthy delivery, she is still around 50 kg below her weight. Now, as far as risk of surgery is concerned, again, this has changed over years. When we started surgery in 2000, the risk of the mortality risk was about 2%.
Sorry, I'm having trouble with the connection.
Sorry.
Please try again in a moment.
So the surgical risk was about 2%, and now it has come down to 0.05%, which is almost the same as that of lap cholecystectomy or a laparoscopic hernia repair. And this is not because we have become more experienced, but because there is a better technology available. The better anesthetists have become more experienced, better anesthetic drugs are available. and better understanding of disease by surgeons and physicians together. And it is also seen that the risk is less in experienced hands, those who are doing high volume surgeries. Just to show you, this gentleman, he was 127 kgs, lost weight, and he's now a regular marathon runner all over the world. I think the change of bariatric happened when in 2013, the central government approved to cover this surgery for their employees and their family members. So anybody with more than 40 BMI and more than 35 with comorbidity, if they are central government employees, their expenses are completely covered by the government. And then in October 2020, from 1st October 2020, all insurance companies are covering bariatric surgery. So now on an average, almost 80% of our patients are completely reimbursed or they go through the cashless route. It's important to realize that there is no pre-existing clause in corporate and family floater policies. The pre-existing clause is only in the individual policy, and that limit is also 4 years. So if anybody has a policy for more than 5 years, the insurance cannot deny payment for their bariatric surgery, irrespective of whether they were overweight before that or they had diabetes before that. So these are the criteria that a physician should know when insurance will cover. So if BMI is more than 40, then insurance has to cover. And if it is more than 35, then one of these 4 conditions has to be there: uncontrolled diabetes, severe sleep apnea, coronary heart disease, or cardiomyopathy. So if one of these 4 are there, that insurance companies are obliged to pay for the bariatric surgery. So thank you so much for patient listening, and I'll be very happy to answer questions related to bariatric surgery or obesity in general along with Dr. Bajan. Dr. Unnati.
Thank you, Dr. Raman. And we do have a question. I will just read out the question for you. Although this question was asked after Dr. Bajan's session, but I think you can also take this. Okay, so the question is, what are the latest clinical guidelines to manage obesity-related cardiovascular complications? What parameters must be monitored in obese individuals to keep track of the comorbid condition?
I think Dr. Bajan is the right person to...
Yes, I think Dr. Bajan is the right person to answer. Is he here with us?
Yeah. Hi. So basically, any obese person, we need to monitor parameters of, we need to do blood tests on insulin levels, the cortisol levels, the lipid levels, the sugars, the glycosylated hemoglobin, and the works. And also look for their blood pressure and other parameters, and even do a psychiatric counseling if they are depressed or have some, low self-esteem. So these are the things that we would need to always monitor them. And earlier the better. Catch the children young, so catch them young. And I think the earlier you do it, rather than people who are 10, 15 years into obesity, then just as the fat becomes stubborn, I think their mind becomes stubborn. And then they are not very prone to either medical or surgical care. And they say, I've lived with it for 15 years, why should I bother? So please, I think we need to make parents aware for childhood obesity and make sure that they are regularly checked, because obesity is now a disease. As Dr. Raman said, it is a disease and we need to address it from the beginning. Otherwise, I showed you the chart of a circle where pubertal obesity can actually, or childhood obesity can lead to adult obesity and complications. So a good monitoring is important. And when comorbidities happen, then definitely it needs to be addressed. But I would go one step further by saying, catch them young. So catch them even before the comorbidities exist.
So doctor, I have one more question related to what we discussed right now. So we know there's a lot of lifestyle difference in the European countries and the Western countries, and there's a lot of lifestyle and dietary difference in our countries. So how do you think post-COVID those countries, are they treating obesity better than us, or are we ahead of them? Like what does the data, what does the statistics say?
Dr. Goel.
Yes, Dr.
So, Dr. Unnati, the issue is that they have a lot of facilities available,
Right.
but they also have more obesity than our countries. Our country means third world countries.
Third world. Yeah, correct.
So on one side, there is a surplus of calorie-dense food which is available. On other side, they have all facilities for cycling track, walking tracks, sports facilities. So I think the government and the society is making all out effort there to control obesity. It is just a matter of time. Some of the countries have been able to reduce or slow down the growth of obesity, like in US now. So they are plateauing, while our country is rapidly growing. So we are in a early phase of a epidemic, let's say, of obesity, while they are turning the curve, as the people in nowadays talk about it. So I think we cannot say that we are doing better or they are doing better. They were there earlier, and they have seen the dangers of obesity and related problem, and they have been able to take corrective measures, while we are just realizing the seriousness of obesity and related comorbidities. And we are probably a long way to go to give a healthy lifestyle to our citizens.
May I just add, Dr. Unnati? Yeah. So exactly what Dr. Ramen Goel said, but we need to make more people aware in India. That is the problem. So even the family doctors, even the physicians, they say, okay, you are just healthy. You know, our parents always call us healthy when we are obese, which is actually the most unhealthy disease. And it affects the children, it affects the younger adults. So trauma and obesity are the only two which are much more in the younger than the older. So nobody is thin and lean up to 50 and then becomes obese, very rarely. So this is to be tackled very early. And that can be done only if the parents, the people around, and the doctors are, the family doctor who actually visits them whenever there is a problem should be made aware that yes, this is a disease and it should be addressed right now.
So very nicely answered, Dr. Bajan. I think that is the sole agenda of our academic program here, so that we can enable our physicians, because they are actually, I think they are the touch points for the people who are, you know, in the remote areas, and because they are the touch point for people who come, because they are the ones who answer their queries first. They are always the first point of contact. So I think our physicians, whoever are here, are taking a lot of insights from this. And thank you both of you again. I don't think we have any other questions. Thank you, Dr. Raman. Thank you, Dr. Khusrav. We really look forward to hear from you again. And thank you for taking out the time. To all our lovely audience out there, I am sure you are gaining a lot of insights here. And we will be back again next Thursday with another session on management of obesity. Also, if you want to be a part of the live audience, please do leave a comment on the chat box and we will get back to you for the same. And I'll see you again soon. So stay safe, stay connected. Happy Docplexing. Bye, doctor. See you soon.
Dr. Unnati, patient Ms. Karobi's video?
Yeah, I'm so sorry. I just completely got that. Okay. So we have with us Ms. Karobi, who is a patient of Dr. Raman. And I think the best person to describe the experience of whatever we are doing is the patient itself. And we have a small interview from Ms. Karobi explaining her journey of, obesity and how she fought it and how she came and how the bariatric surgery helped her through this. So can we have her interview, please?
Karobi is from Kolkata. And
Yes.
she came here for her bariatric surgery sometime
In
back.
2019, right? Doctor, when was she operated?
Yeah.
2019.
Yeah. So they recorded her interview yesterday, I think, morning. And it's a brief interview. Pratik, can we play it, please?
My name is Karobi Chaudhary. मैं कोलकाता वेस्ट बंगाल से हूँ. मैं 2019 में मैं बैरिएट्रिक कर चुकी हूँ क्योंकि मैं बहुत प्रॉब्लम्स फेस कर रही थी. बैरिएट्रिक से पहले मेरे ब्रेथलेसनेस थे. मैं ज्यादा दूर तक वॉक नहीं कर पाती थी. मैं स्लीप एपनिया भी थी, बट मैं डायबिटिक नहीं थी. स्टेयर्स चढ़ने में भी मेरा दिक्कत होता था. लेकिन अभी 2019 में डॉक्टर गोयल का अंडर में मैं ऑपरेशन बैरिएट्रिक का ऑपरेशन किया है उन्होंने, और डॉक्टर मधु गोयल ने मेरा बहुत ही केयर किए हैं। इसके बाद जैसा जैसा उन्होंने प्रोग्रेस करवाने के लिए मेरे साथ जो फाइल में जो थी लिस्ट थी उसी फॉलो करके हम प्रोग्रेस की, बहुत ज्यादा प्रोग्रेस की। मैं इतना दिन में मैं 53 केजीज लॉस्ट किए हूँ, क्योंकि मैं पहले 143 केजी थी। अभी मेरा वेट है 94 केजीज। नाउ आई कैन वॉक अप टू 20 to 30 मिनट्स। मैं स्टेयर्स भी चढ़ सकती हूँ, मैं ब्रेथलेसनेस भी नहीं है मेरा, क्वाइट ओके। मैं थायराइड के पेशेंट हूँ। अभी डॉक्टर मैम मधु गोयल के अंदर में उन्होंने मेरा 125 एल्ट्रॉक्सिल का पावर कर दिए हैं, उन्हीं का चार्ट मैं फॉलो कर रही हूँ। अभी मैं पहले से बेहतर हूँ। अभी मुझे कोई शर्म नहीं लगता है रोड पर निकलने के लिए, चाहे वॉकिंग में जाऊं चाहे कहीं पे भी जाऊं, लेकिन मुझे शेम नहीं फील होता है। अभी क्वाइट कॉन्फिडेंट हूँ मैं अभी पहले से।
कारोबी जी, आपका ये जर्नी सुन के बहुत अच्छा लगा। इट वाज ग्रेट नोइंग दैट अब आप अच्छे से रिकवर कर गए। तो सर्जरी के बाद रिकवरी होने में आपको अपने नॉर्मल लाइफस्टाइल आने में कितना टाइम लगा?
नॉर्मल लाइफ ज्यादा दिन तक नहीं लगा, मुझे तो बहुत जल्द ही आ गया, क्योंकि हॉस्पिटल से रिटर्न करने के बाद भी मैं हल्का फुल्का काम करने शुरू कर दी। मैं कभी सो के नहीं रही। थोड़ा थोड़ी मेरा हाउस होल्ड वर्क तो मुझे करना ही पड़ा, मैं तो करती ही थी। अभी भी मैं बहुत ज्यादा करती हूँ, लॉन्ग टाइम तक खड़ा हो ना सकती हूँ। बाहर जाती हूँ मैं वॉक के लिए, मॉर्निंग वॉक के लिए, कहीं घूमने जाती भी हूँ, फिर भी मुझे कोई तकलीफ नहीं होता है स्टेयर्स चढ़ने में, चाहे स्टेयर्स उतरने में, चाहे कोई भी काम में, चाहे नींद में भी ब्रेथलेसनेस मैं फील नहीं करती हूँ। अभी मैं बाइटैप भी यूज नहीं करती हूँ। अभी मैं बहुत ही ठीक हूँ।
Great to know that and we are very happy to know that आपने इतना अच्छा रिकवर कर लिया है। अच्छा, एक क्वेश्चन और है आपके लिए, जैसे सर्जरी के बाद आपको अपने खाने पीने में क्या चेंजेस करने पड़े?
खाने पीने में देखिए, पहले जैसे तो मैं ऑयली फूड्स नहीं लेती हूँ। कुछ लेने से पहले मुझे सोचना पड़ता है कि मैं ये खाऊं, ये मेरे सेहत के लिए ठीक है कि नहीं। सुबेरे मैं एक स्कूप प्रोटीन ले लेती हूँ और 2 टोस्ट ब्राउन ब्रेड, और दोपहर को 6 to 7 tablespoon rice, vegetables, and as we are Bengali, we take fish. One fish is coffee. 50 grams of fish is just okay for me. At 3 o'clock, I take fruits and chena, and at night also in dinner, I take 6 to 7 tablespoon rice and a cup of dal and थोड़ा सा vegetable. यही मेरा मेनू है, डाइट चार्ट।
ग्रेट कारोबी जी, बहुत बहुत धन्यवाद। आपने काफी अच्छे से एक्सप्लेन किया है एंड ऑल द बेस्ट। जो भी आप कर रहे हैं कंटिन्यू करते रहिए, और आपका ये वीडियो आई एम श्योर बहुत लोगों को, बहुत सारे डॉक्टर्स को भी इंस्पायर करेगा, ताकि वो और पेशेंट्स को बताएं।
मैं और एक बात मैं अंत में कहना चाहती हूँ।
बिल्कुल ऑफ कोर्स,
क्योंकि मेरी लाइफ गिफ्टेड बाय डॉक्टर रमेन गोयल एंड डॉक्टर मैम मधु गोयल, because without them I won't be so much successful. Till now, Dr. Ma'am Madhu Goel guides us, and I am quite fine and quite okay in her guidance.
Karobi ji, thank you so much.
व्हील चेयर में गई थी, मैं वॉक करके घर आई हूँ।
I know. और वेट लॉस अच्छा है आपका।
मुझे दिया है वो बॉम्बे स्टेशन में आप सोच नहीं पाएंगे। फर्स्ट प्लेटफॉर्म से लेके 16th प्लेटफॉर्म तक लगेज लेके चलना, ये कोई मामूली बात नहीं है। बैरिएट्रिक के बाद ही ये सफल हुआ है।
एक्सीलेंट, वेरी गुड।
वहाँ पर भी और यहाँ हावड़ा में भी इतना मैं पैदल चल के आई, वो मैं आपसे कह नहीं पाऊंगी। लगेज लेके, वो भी मैं और मेरे हस्बैंड।
एक्सीलेंट।
कोई नहीं था साथ में, लेकिन हम दोनों आए हैं आपके लिए। आप और मैम के लिए इतना कॉन्फिडेंट मेरे में जगह है जो मैं कह नहीं पाऊंगी।
वेरी गुड। नहीं, मुझे ध्यान है आपका, जब आप आए थे दोनों, और शुरू में आपका फिटनेस नहीं मिल रहा था ना, स्लीप एप्निया की वजह से।
हाँ, बहुत याद है सर। बहुत
आप
याद
पहले
है।
कहीं पे एडमिट भी हुए थे ना एक बार स्लीप एप्निया
नहीं,
की वजह से।
वो जो क्या थे उनके लगदा वाला जी का सर का वहां पर गए थे, लेकिन वो हमारे नहीं आया। आप कॉन्फिडेंस नहीं मिला उतना जितना आपको पास में हमें कॉन्फिडेंस मिला।
ठीक
मेरे
है।
दोनों बेटों भी बोला जी नहीं यहाँ पर ही करना है सर के अंदर में। ओके, थैंक्स।
Karovi,
All
thank you
right.
so much.
Thank you so much. Thank you, Dr. Raman. Thank you for taking out the time. Thank you, Kairovi ji. ध्यान रखिएगा. We will see you soon.
Yes.
Bye.
Bye.
So, Dr. Bajan, this is what the
Superb.
pediatric
Appreciate
is
the
all
work,
about.
Dr. Raman. I mean, the patient, it was clearly visible, when she was talking that how happy she is and how it has changed everything. We all
talk
appreciate.
about cosmetic part of it, but look at this lady. I mean, at 143 kgs at this age, she was already quite good looking when she came to us, and imagine that she lost another 53 kgs.
Right.
For somebody who finds it difficult to walk, also losing 50 plus kgs is substantial.
And I think she had all the classic comorbidities of obesity, the sleep apnea, the dyslipidemia, everything and all that. If we look at it from the disease part, I think it really did wonders for her. And appreciate all the efforts, appreciate for you to start this academic program so that we can make more and more physicians, aware about the same thing. Thank you for your time. Is that all? I do not think we have any other questions from the audience.
Thank you.
Yeah, we'll see you next Thursday.
Thank you, Dr. Bajan.
Thank you, Dr.
Raman,
Bajan. Please stay in
Raman,
touch.
excellent
Academic program
work
so that
and
we can make
the
more and
quality
more
of life that you give
physicians,
patients
aware
is
about the
really,
same
really
thing.
commendable.
Thank you for your
So
time.
keep on
Is
the
that
good
all?
work.
I do not think we have any other questions. Bajan, it was amazing.
Thank
I'm
you.
sure you're doing an amazing see you next Thursday and we will see you soon.
Thank you,
All
Dr.
right?
Bajan.
Okay. Bye, Dr. Bajan. Please stay in touch. Academic
Excellent work
program so that
and
we can make
the
more and
quality
more
of life that you give
physicians,
patients
aware
is
about